DINE-CD study. We know that a topic of major interest within the IBD community is the role that diet plays in the management of Crohn's disease and ulcerative colitis. In 2016, the foundation received a grant from the Patient-Centered Outcomes Research Institute to look at 2 diets and their ability to induce remission in Crohn's patients. At the end of May, the results of the study were published, and we're excited to share them with you today. I am joined by Dr. Jim Lewis from the University of Pennsylvania, the study's principal investigator, to provide us with some of the findings from this study. Thank you for joining us today, Dr. Lewis.
Thanks, Michelle, for your interest and for inviting me to meet with you today.
Definitely. Before we get started, let's go over a few quick pieces of housekeeping. The information provided during today's chat is meant for educational purposes only. IBD is experienced differently by every patient. There is no one diet that works for all IBD patients. We encourage patients to work with their GI and a dietitian to figure out what foods do or do not work for them. The views shared during today's chat do not represent the official position of the foundation. Always consult with a physician when making changes to your IBD treatment regimen. And as usual, tonight's topic is diet and nutrition. If you have questions about other topics related to IBD, we won't have time to get to them tonight. But we encourage you to contact the IBD Help Center with your questions at info@crohnscolitisfoundation.org or call 888-MY-GUT-PAIN. With all of that out of the way, let's get started. Dr. Lewis, can you tell me why you were interested in studying the role of diet in IBD?
Well, I think that my interest in diet actually, ironically, goes way back when I was a resident. My first child was born, and I was talking to one of my resident advisors, Rosemary Fisher, and she ironically had been contracted to write a chapter about the role of nutrition in inflammatory bowel disease. And she asked me if I would work on her with this. And I date this based on the birth of my first son, not that that's relevant to the conversation. But little did I know at that moment that I would spend so much of my career thinking about this. That, as background, but the reality is now, 20 plus years of taking care of patients with Crohn's disease and ulcerative colitis, I know that patients all the time ask, what's good for me to eat? What's bad for me to eat? Is there anything I should avoid? Is there anything that I can eat that will make me better? And I think up until now, we just haven't had really great data to be able to give a wise and sage advice to our patients to answer that. And it turns out that within a network of patients where they had the opportunity to pose questions, this was, again, this sort of jump to the top as one of the things that patients really wanted to know about.
Yeah, can you tell me a little bit more about how you collaborated and worked with patients to come up with the idea for this study?
Yeah, I want to give most of this credit to Bob Sandler and Mike Kappelman, who have worked super hard to put together a cohort of patients referred to as IBD Partners. And I would say to anybody out there who, if you want the lowest barrier entry into participating in research, sign up to be an IBD Partners member. All you have to do is every so often fill out a survey. But in any case, in the IBD Partners platform, patients have the ability to pose questions that they think it would be important to get an answer to. And then other patients can go in and endorse those questions so that we, people like myself as investigators, can see, oh, this was the question that got, if you will, the most votes, the most endorsement. And early in the creation of IBD Partners, one of these questions that really rose to the top was, does diet work as a treatment for Crohn's disease? And in particular, people had an interest, they wanted to know about specific carbohydrate diet. There are lots of different diets that have been tried to treat IBD. This was one that patients were particularly interested in.
Interesting, thank you. What makes this DINE-CD study unique?
I think there are a lot of things that make it unique. Every trial, every study of nutrition has its own challenges. One of the things that's unique about this was that patients really were the ones that posed the question in many ways. We worked with patients to refine that question and design the trial. It's also, to my knowledge, the first large-scale trial of a diet therapy based on whole foods that's been conducted in the United States. And I think, to my knowledge, it's the first large-scale controlled trial that has looked at specific carbohydrate diet. And when I say controlled trial, meaning that there was a control group who got a different diet, and was where the two diets were assigned at random, and we were able to evaluate head to head to see whether specific carbohydrate diet would do better, the same, or worse than the control diet. Lots of studies have been done without a control group, and I think it's very important for people who are looking at data on the role of diet to understand that in the absence of a control group, it is very hard to know whether the intervention actually had an effect, or was that just what was going to happen to patients anyway.
Right. What were you looking for in the DINE-CD study? Like what factors were you trying to assess?
So the main question in the DINE-CD study was whether specific carbohydrate diet was more effective than a Mediterranean diet to achieve symptomatic remission for people with Crohn's disease who had mild to moderate symptoms. We asked a lot of secondary questions, but that was really the core question that was what drove the design of the study.
What made you choose to compare specifically the Mediterranean style diet versus the specific carbohydrate diet?
Well, that's certainly the million-dollar question. And we thought long and hard about this. And really, it came down to two different alternatives that we were choosing between. One alternative was just continue your regular diet as the control group. And the second alternative was Mediterranean diet. And I'll give you the rationale for both, and then how we settled on Mediterranean diet. The Mediterranean diet has been shown to people who consume a more Mediterranean style diet appear to be less likely to go on to develop Crohn's disease. So it had that going for it. And there's been a little bit of data suggesting that people who followed a Mediterranean diet may have better symptom control of their IBD. And thirdly, people who follow a Mediterranean diet have been shown to have numerous other health benefits. In particular, they tend to live longer, they tend to have less cancer, and they tend to have less cardiovascular disease. And that has led the USDA to adapt our guidance on what all Americans should be consuming to a diet that is generally reflective of a Mediterranean diet. And maybe this would be a good moment to just sort of describe that for people who are watching.
That'd be great. Thank you.
That a Mediterranean diet is characterized by high levels of consumption of fresh fruits and vegetables, moderate consumptions of fish and a bit of poultry, very limited consumption of red meats, and sweets and sugars, refined sugars of that nature. It also tends to have olive oil as the primary source of fats, and it encourages nuts as another good source of healthy fats. And in the sort of classical description, it includes a small amount of red wine with meals. We're going to come back to how we did Mediterranean diet, so people could have had that red wine, but we weren't providing it. But in any case, so our sort of USDA guidance says that's what we should be consuming. There's reason to think it had lots of health benefits and some evidence that it may be beneficial in Crohn's disease. So that was one choice. The other choice was to let people, as the control arm, just continue to eat their regular diet. And in many ways, that would have been a really appealing control group because it's what people were doing anyway, whereas following a more Mediterranean diet, for most Americans, that's a change in our dietary pattern. The reason we didn't go with following your own diet as the control group is we thought that it would be very challenging to recruit people to participate in the study by saying to them, we want to choose by chance whether you're going to follow the specific carbohydrate diet or just keep following your own diet for the next 3 months to see what happens. If you're not feeling well, you're looking for something to make yourself feel better and saying, well, just keep doing the same thing for the next 3 months and we'll see what happens. We thought that was going to be a giant barrier to recruitment. So we decided to compare specific carbohydrate diet to the Mediterranean diet for all the reasons that I noted. So then with that, maybe I should also take a minute and just describe specific carbohydrate diet because many people may not be familiar with that.
Sure.
So specific carbohydrate diet has been around for a long time. It actually, probably some of its earliest use described therapeutic benefits was for celiac disease before we even knew that gluten was the driving problem for celiac disease. And it turns out that one of the features of specific carbohydrate diet is that it is a gluten-free diet. So not surprisingly, people with celiac disease got better. So specific carbohydrate diet is characterized mostly by the carbohydrates or sugars that you consume. So it takes all the grains out of people's diet. It limits dairy essentially to a few cheeses and yogurt that has been fermented for 24 hours to minimize any remaining lactose that would be in the yogurt. To put that into context, to get yogurt that's been fermented for 24 hours, you pretty much have to make your own yogurt because commercial yogurt has only been fermented for a few hours. It does allow people to consume most fruits and vegetables, most fresh meats, but not any processed meats. So where a Mediterranean diet is going to limit your amount of red meat, specific carbohydrate doesn't specify that, but it does get rid of any sort of processed meats because that tends to have other of these sugars in it that we're trying to avoid.
Thank you. Who was eligible to participate in the study?
So we designed the study for people with Crohn's disease with mild to moderate symptoms. We were not looking for the ultra sick person who was about to wind up in the hospital. We excluded people who had known strictures or narrowing of their intestines because on both of these diets, people were going to wind up eating more fruits and vegetables than maybe they were accustomed to, and we didn't want people to get into trouble with that. So the main inclusion criteria were mild to moderate symptoms, you have Crohn's disease, you don't have a significant stricture, and you didn't have an ileostomy or colostomy.
Can you elaborate a little bit on why patients with an ostomy weren't eligible to participate?
It's an unfortunate feature of the way we do clinical trials. This is a group that is largely ignored in clinical trials because the tools that we use to measure people's symptoms and their response to therapy are not reliable when people have an ostomy. And in essence, this is because one of the things that we tend to measure, think about what are the sort of core or cardinal symptoms of Crohn's disease. Among those are abdominal pain, but also your bowel frequency and how much diarrhea you're having. And this bowel frequency and diarrhea is very difficult to measure in someone who has an ostomy. So unfortunately, patients with ostomy tend to be ignored from clinical trials, and we have to hope that we can extrapolate the results that we see in other patients to those with an ostomy. And it would be a great source of resource for someone to come up with a way that we could include these patients in clinical trials.
Thank you. How was the study designed and what did participation entail?
The study lasted for 12 weeks after people started the diets. The two groups were randomly assigned to either follow a specific carbohydrate diet or Mediterranean diet. And one of the unique features of this trial, and I should say only possible because of the support of the Crohn's and Colitis Foundation, was that we were able to provide prepared meals, breakfast, lunch, and dinner, and 2 snacks a day for the first 6 weeks of the trial. That meals being compliant with the diet that you were assigned to. The meals were prepared by a vendor from fresh ingredients, and people would get a delivery on Fridays. They would get a big box with all of their food. All they had to do with the food was essentially heat and eat. Some things you didn't need to heat, but those, you could either microwave or put it in the oven. So different from the services which are providing raw ingredients and then you had to prepare your own meal. These were really prepared meals ready for you to eat. So we couldn't make things any easier for people in the first 6 weeks. But then in the second 6 weeks, people were on their own to provide their own food. They did have the option of purchasing food from our vendor, but I would say very few people actually did that. And then at 6 weeks, we assessed for the main outcomes, which was what we refer to as symptomatic remission. So we used a sort of tool to measure people's symptoms. And the question was, could we get people to be symptom-free? We also measured, as some of our most important secondary outcomes, were reduction in inflammation in those people who had clear-cut evidence of inflammation coming into the trial. And we did that by measuring stool calprotectin and CRP, which are commonly used biomarkers that many of the patients who may be watching would say, oh yeah, my doctor measures those things in me all the time.
Thank you. So you were talking about how in the first half of the study you were using a food vendor, and then for the second half of the study, the patients, for the most part, prepared their own food. How did you position these patients to be in a place where they could successfully adhere to their assigned diet and self-maintain? Yeah,
it's a really good question. And part of this was we viewed the first 6 weeks as training, the training of sort of making your brain sort of realize, well, this is what I can eat and what I can't eat. We obviously provided people with lots of educational materials about that. There was a special website they could go to that was unique to their diet. There was a dietitian that they could ask questions of. And they could actually even get access to some of the recipes for the foods that were being provided. But the goal was that in the first 6 weeks, people would sort of learn, okay, this is what I can eat. They would figure out how to do it and then go on and make their foods. I will point out that for specific carbohydrate diet, there are a lot of resources out there that people can follow to say, all right, these foods are allowed and these foods are not allowed. So, if you're good at following directions, recipes, rules, etc., in some ways the specific carbohydrate diet makes total sense because we tell you exactly what you should eat and not eat. The Mediterranean diet, on the other hand, for the participants takes a little bit more judgment. I gave you the sort of core principles about lots of fruits and vegetables, fish, a little bit of poultry, avoiding red meat, sweets, etc., using lots of olive oil and nuts. But there's no list that says, oh, I can't eat this if I'm on the Mediterranean diet, or I can't eat this. Even, the Mediterranean diet doesn't say you would never have any sweets. You just would have very, very little. So it's a much less rigid approach. And so there we provided the same sort of training, but it probably for some people, like there wasn't that go-to list to say, oh, I'm allowed to eat this, I'm not allowed to eat that. Right.
So talking about the study's findings, what did you do after analyzing the results of the study?
So maybe I'm not sure I actually shared the main findings yet, but let me do that. So the main findings were that after 6 weeks on the two diets, so half the people on one and half on the other, about half of the people had achieved symptomatic remission. And perhaps the most striking feature of the study was that there was absolutely no difference no matter of which diet you were on. On both of these diets, about half the people who enrolled in the trial with mild to moderate symptoms of Crohn's disease by 6 weeks would meet a definition of what we would say they were completely asymptomatic. So that's a glass half full or half empty, depending on how you view this. The half full is that 50% of the people were better, and all we had done was change their diet. We hadn't changed their medications. The half empty is, going into the study, I would have loved to be able to tell you diet A is much better than diet B, or diet B is much better than diet A. And what I'm left with is telling you it didn't matter which one they went on. In both cases, 50% of the people felt better at that time point. In terms of the inflammatory markers, the stool marker calprotectin, about a quarter of the people had a meaningful improvement in that marker, meaning they had to get below a threshold and they had to have had their levels go down by 50%. So they had to have a fairly sizable drop in the inflammatory markers. And again, that was not significantly different between the two diets. And then the blood markers of inflammation, the glass was much more empty in that one. So when we measured CRP, really only about 5% of the people by 6 weeks had normalization of their CRP and at least a 50% reduction. And that was only, we only were measuring that among the people who were abnormal at baseline. There were lots of people who had normal CRPs coming in, and they still had normal CRPs at 6 weeks. But of those that were abnormal, we didn't find that either of these diets were particularly effective at normalizing that serum marker, that blood marker of inflammation.
Right. So I think this question is very similar to the statements you were just making, but to regroup and clarify for our viewers, the difference between experiencing symptomatic remission and clinical remission, the ways that you were defining clinical remission are those markers you were mentioning, correct?
Yeah, well, so, and in addition, we also measured, so we measured symptoms in two different ways. We used one tool that's called a short CDI that was just based purely on symptoms. People would tell us about how much diarrhea they were having, how much belly pain they were having, and what their general well-being was. How did they feel overall? And that was our main outcome measure. But we also used another tool called the Crohn's Disease Activity Index, the full scale of that, which takes into account some physical exam findings, what's happening to people's weight, what happened to their hematocrit, and some other markers, so that it's really sort of the traditional metric that's used in most Crohn's disease clinical trials that were done to get medications approved. The short version, that's just their symptoms, is designed to be all about the patient's experience, but correlates very, very highly because many of the questions are the same. And it turned out when we looked at this more traditional metric, the results were essentially identical. About 50% would have met a standard clinical trial definition of remission at 6 weeks.
Thank you. Aside from helping with disease symptoms, what other benefits did patients experience when they started one of these diets?
Yeah, this is really interesting. We're actually still doing we're analyzing some of these data now, even more than what we've published. But in both diets, people really had a lot of other symptoms that got better. They had improvement in fatigue. They, for example, they had improvement in their sense of social isolation. I was actually worried they were going to feel more socially isolated. They didn't see this happening. So we had measured a number of these sort of extra symptoms, which really seemed to improve for them in both groups, which was really nice to see. Another one that they had, I mentioned fatigue. So people reported in both groups that their sleep got better. They also reported having less pain that was interfering with their day. So across the board, their quality of life was getting better. And we also used a generic, I shouldn't say generic, a IBD specific quality of life measure, which is referred to as the short IBDQ. And in both groups, they had significant improvement in their symptoms. So taken as a whole, didn't matter which diet these people went on, they felt better. Both their sort of core symptoms and a lot of these extra symptoms.
That's great. Are there any plans to conduct a similar study with ulcerative colitis patients?
So we would love to. That would be great. This is a gigantic undertaking to do this. There are other people who are doing studies today of ulcerative colitis with some different diets, and so hopefully we'll see some new information forthcoming before too long. The sort of dietary counseling for people with ulcerative colitis probably is, on the whole, not that different from patients with Crohn's disease, in that I think what modern diet-related research is showing us is we don't need to really avoid fruits and vegetables outright. There may be people when they're really, really sick who aren't going to do great with a lot of fruits and vegetables, but for people with sort of mild to moderate symptoms, we maybe shouldn't be so afraid of fruits and vegetables as we often have been. And there almost certainly are a number of sort of health benefits that are related to consuming these fruits and vegetables.
How can the results of this study change the way we use diet as part of treating IBD in the future?
I guess the way I think about this is that the diet can have a couple different roles. And it's very important to figure out from the patient what their goals are. For most of the people who come in and ask the question I started with, which was, wow, I have Crohn's disease, what should I be eating? They're probably not thinking about using diet as their sole source of therapy. Their goal is, I understand I'm going to have to probably take these medications, but are there things that I should eat or not eat that will reduce the likelihood that I'm going to feel poorly? And there, I think, a recommendation for a diet that follows the core principles of a Mediterranean diet makes a lot of sense. It seems to result in people feeling better on average, or at least about half of the people. And it has all these other health benefits that I told you about. If somebody says to me, well, I've read about this specific carbohydrate diet and I want to try it, I explain our comparison of these two results and say, I'm happy to support you in that. And regardless of which one of these diets they try, I'd say to them, look, we have to go into this the same as if we were going in with a medical therapy. We want you to feel better and we want your inflammation to go away. So after you've been on this, we're going to monitor your inflammation and try and figure out whether it's getting better. And if it's not, we're going to have to at least consider what our options are. I think I would be remiss if I didn't point out, though, these are two diets that we studied. There are other diets that people have been using for Crohn's disease in the past, and diets that are in development. The best evidence that's been put out over decades is using a formula-based diet, but that doesn't have, people can't stay on that for a long time, like living exclusively on drinking, a formula. Right. A diet that's gotten a lot of recent popularity is called Crohn's disease exclusion diet. And it's been shown to have some therapeutic benefit in a controlled trial. And so that's encouraging also. And there's a number of other ones that are out there. So if somebody comes to me and says, how can I use diet to make my Crohn's disease better? We're going to talk about a bunch of different diet options, figure out how it fits with their goals of care, and how we can make it work with what our joint goals are.
Thank you. That's all the time we have for today's chat. Dr. Lewis, thank you so much for joining us and for sharing the findings from the DINE-CD study. Do you have anything else you'd like to add before we sign off?
Yeah, well, first, these sort of studies, I don't know if people realize how much work it takes to do a study like this. We did this in over 30 centers around the United States. If you count all the people who were screened and enrolled in the trial, it was hundreds of patients who were willing to participate in a trial like this. It's a huge effort, and it wouldn't be possible without all those other people who participated. We had funding from PCORI that you pointed out at the beginning, but also the Crohn's and Colitis Foundation supported this trial. I had a Sherman Prize that helped support some of the work of this trial. So I certainly didn't coin the phrase, it takes a village, but these are village-like undertakings, and it wouldn't be possible without them. And so I am just offering my thanks to both the patients who participated, but also the investigators, the funders, everybody who made this possible, and look forward to there being much more nutrition-related research in the future. And on that, I would say thank you again for your interest in the topic and the work, and it was really great to be here.
Thank you. I think the information you shared tonight is very helpful for IBD patients. If you had a question about the DINE study that was not answered tonight, please contact our IBD Help Center at info@Crohn'sColitisFoundation.org or call 888-694-8872. Have a great night, everyone. Good night.
Good night.